So there are various techniques developed over the last few years for resecting liver. So the first one is CRUSA. The one on the right is called radiofrequency tip, Q-tip. And this one here is keyhole operation, laparoscopic liver resection. And then Professor Habib, who can't be here today, he developed his own device called Habib Sealer, which is on the bottom right-hand side. And all of those tools are designed to reduce intraoperative blood loss, hence the recovery. So this is a patient. I had a 45-year-old lady came in with bit of abdominal pain and generally feeling unwell. She's as a post office worker. So I GP scanned her and I found this large tumor on the right side. You can see the big mass on the right side of her liver. And then she was referred to me for resection. I had a look at the tumor. I said, yes, I can do a resection, but the volume which is going to be left behind is on the left-hand side. You can see that coil in the middle of this thing here. So we put in radiologically to enhance the growth, stimulate regeneration of the liver on the left-hand side, because she had very small left lobe, which will be future remnant liver after I remove that tumor. So we do something to stimulate the growth of left lobe of liver. So you compare those two scans. First, you see the size of tumor different, and the second thing you will see the size of the left lobe of liver, which is on the left-hand side of that coil. It's much bigger on that side, but tumor is much smaller. So I felt personally, I said the best treatment for her at the time, I personally felt was to give her chemotherapy Gleevec to downstage the tumor first. Although the evidence is not very strong, in this case she's very young, I would give her the benefit of downstaging. So we kept a close eye on her. That means to scan her regularly, make sure tumor hasn't progressed during the chemotherapy. And she's lucky when she responded to chemotherapy very well. You can see the size of tumor. The two things happen when the size of tumor considerably reduced. See that at least 60% reduction in size. But if you look at what's inside the tumor, is changed as well. This is a solid tumor that became cystic tumor. Yeah, so she responded very well, but nonetheless, she still had the primary tumor. So the plan was to go in to remove that. So she had a resection of that lobe of the liver. And after resection, this is the one on the left-hand side was immediately 3 months after resection. She was well. That was in 17th of November last year. And the latest scans, April of 4th of January this year, she had no disease at all, completely free. And the other thing we do is laparoscopic liver resection, and I reported in my own series, published a couple of papers on this. Essentially, if it's a small liver resection, we can do it with keyhole. Recovery is much quicker, and patients stay in hospital 24, 48 hours. They can go home next day. And as with conventional liver resection, which we have to make a big incision, big cut, lots of bleeding, recovery is normally they need to stay in hospital for 5 to 10 days. So it's an advantage of laparoscopic surgery. And Judy said you should talk a little bit about radiofrequency ablation as well. I thought I'd just throw in a couple of slides because, believe it or not, we published this paper back in 1998 to use radiofrequency in treating liver cancer. Liver cancer means primary cancer and secondary liver tumor. We published this after we presented this in 1998 in Madrid. There was International Hepatobiliary meeting, so liver, gallbladder, pancreas. So all the big heads from the world was there. I remember very clearly there was a guy from America criticized me, say, why are you using this technique to treat patients with unresectable liver cancer, metastatic cancer, because it's very unethical, because there's no data to support use of radiofrequency ablation, and all you do is prolong the life, but they have unresectable disease. I said, no, I told him, said, yeah, we do need evidence to support use of this, but the benefit is quite clear. using this technique. At the time, we said we use this technique for unresectable cancer. I still remain the believer of that statement. And also we proposed, I mentioned to Judith as well, we can use this technique to select patients downstage the tumor in both lobes of liver. We can concentrate on ablating one side which has a fewer number of tumor and then remove the other side which has more tumor. For example, we can actually select patient for liver resection and then to completely clear the liver tumor completely with combination of surgery and radiofrequency ablation. I mean, 20 years on, I'm afraid there's still no randomized controlled trial, and you probably realize that everybody is using that. This actually data from colorectal. Most work was done on the colorectal liver metastasis, comparing radiofrequency ablation versus liver resection. You can see liver resection still remains the gold standard treatment in terms of reduced local recurrence rate and survival. So both survival and recurrence rate, survival much better, recurrence rate much lower if you compare surgery with radiofrequency ablation. And then radiofrequency ablation can be deployed in different ways. Laparotomy, be cut, percutaneous from outside, or can do it laparoscopically. This is a summary of the different approach to radiofrequency. You can see if a tumor is over 5 centimeter, unfortunately not very effective because we can't assess how complete a tumor has been ablated. Especially difficult with percutaneous approach because it's done with ultrasound guidance most of the time. Once you start the radiofrequency process, it will be very difficult to mark out where is the tumor being ablated. So there's still lots of research to be done and try to actually assess the completeness of radiofrequency ablation. The size does matter. If less than 3 centimeter, the result is very good, but if it's over 5 centimeter, it's very difficult to achieve complete ablation. Again, this is from Dr. Foster national data. We are lucky. We have a margin is good, the bottom there, and we have a lowest mortality rate for major liver resection. So to conclude, that surgery remains the standard treatment for primary GIST, and Gleevec obviously improved survival and also increased number of cases suitable for surgical resection in patients with metastatic GIST tumor. And of course, surgery is best used in combination with chemotherapy, which will give the best benefit and also improve the overall long-term survival. I think as with all cancer, especially rare cancer, this is my personal interest. My interest in pancreatic cancer, I thought probably is a little bit relevant because I think the key is early diagnosis for those patients with no symptom or very non-specific symptoms, and then really need to get GP excited for early intervention. Early intervention means early detection of cancer. So if you detect cancer at a small size, I mean, this is very clear from pancreatic cancer. If the tumor is less than 2 centimeters, survival is much better than people who have tumor over 2 or 4 centimeters. So early detection is key for any cancer. Unfortunately, because rare cancer is very difficult to introduce the program for early detection of different type of cancer. So at Hammersmith, I personally set up this thing. I'm pushing GPs to try to screen people. I'm interested in people who have hereditary problem of pancreatic cancer, and also target those which we found incidentally to have tumor in the pancreas, cystic tumor, benign tumor, follow them closely. So if there's any change, we intervene much early. I think in a way, pancreatic cancer is similar to GIST in that it actually takes about 20 years to develop detectable pancreatic cancer. And we have now a lot of evidence to support that. So 11.9 years to have cancer, and another 8 to 10 years to develop detectable pancreatic cancer. So I think it's key to actually detect those cancer early. So I'm trying to push everybody to, if they have, somebody comes with bit of abdominal pain, try to do a CT scan, and an early intervention for people with a smaller tumor, and we identify markers which we can use to screen the tumor at early stage. Of course, I think Judy's and your group is fantastic. I think we need people like you to drive the science and drive everything forward to raise the public awareness, because it is rare cancer. Most people never heard of it. So I think it's your enthusiasm and support will make science advance and help us to actually find a way to improve long-term survival for patients with cancer. Thank you very much.